Alright folks, we're gonna get started. Catching up on weekend activities. Alright, so today we have a special guest for the lecture series. Dr. Justin Chan is visiting us. He's the director of the Viral Hepatitis Services at NYC Health and Hospitals. And this is a bit of a homecoming for you, right? Because you did your medical school training here and went to MGH for residency and ID training, and now is back here in New York. So we're pleased to have him give us a talk on his experience treating viral hepatitis sort of in the trenches in the correctional system. So thank you.
Thank you, Gene. Thank you, everyone, for coming. My name is Justin Chan. I'm an infectious disease doctor in the Correctional Health Service in the New York City jail system. Correctional Health Service provides health care to all the jail inmates in the New York City jail system. This is an area of healthcare that I didn't have much exposure to during training. And I think it's, I hope I can show you that it's an area where, as healthcare providers, we can provide tremendous individual and public health impact on an underserved population. So I'm going to talk to you today about hepatitis C in the New York City jail system. My objectives are to go over hepatitis C epidemiology in the U.S. correctional system and also the New York City jail system. And I'm also going to share some data from the Correctional Health Service Hepatitis C program. As an outline of my talk, I'm going to first talk a little bit generally about the correctional health population, characterize them, and also going to go over epidemiology of hepatitis C in the correctional system compared to the general population in the U.S. And then lastly, I'm going to go over the outcomes of our hepatitis C program, including the treatment outcomes for initial cohort and the overall cascade of care. So these are some statistics on the U.S. correctional system. There's two main categories. There's prisons, which house people who are sentenced for greater than 1 year. And then there's jails, which is what New York City jail system is. We detain people that are either awaiting trial, they're pre-sentence, or they've been sentenced to less than a year. The U.S. Incarcerates at a very high rate relative to the rest of the world. There are about 1.5 million prisoners in 2017 and over 10 million jail admissions that year. These rates are coming down over the peak from the last 10 years, but they're still dramatically higher than the rest of the world. Some of the notable trends are that most inmates are men. There are dramatic disparities, racial and ethnic disparities, with black residents being incarcerated at far higher rates than the general population. And the dynamics between prisons and jails are important to understand. U.S. jails have a very high turnover rate. Median length of stay generally is about 15 days. And if you look at the admissions, there's about 19 times the turnover rate in jails relative to federal and state prisons. And you'll notice that a large proportion of federal and state prisoners are serving time for drug offenses. And when you break it down between women and men, a larger proportion of women are serving time for drug offenses than men. And this does come into play in terms of hepatitis C epidemiology. This is Rikers Island, which is an island off of Queens. This island has most of the jail facilities in the New York City jail system. but there are 3 other borough facilities. The jail population has been coming down over the past several years. We are still admitting nearly between 40 to 50,000 patients a year, and the average daily population for fiscal year 2018 was under 9,000. Now we've gotten recently below 8,000, and there's a push to close several of the jail facilities. The same racial ethnic disparities are seen in our system, with majority non-Hispanic, Black, and Hispanic. And these are some useful length of stay statistics. A large proportion are staying for fewer than 4 days, but there is a group that does stay for longer, either waiting for trial or sentenced for less than a year. So this is useful in terms of the types of medical interventions we can provide. The incarcerated population does carry a heavy burden of mental health, medical, and substance use disorder. This is data from a meta-analysis of 24 studies from 10 countries. There's a lot of heterogeneity, but the pooled prevalence estimate of substance use disorder among male inmates is around 30% versus over 50% for female inmates. And this is data from a survey of U.S. correctional facilities, both jails and prisons. Cirrhosis and hepatitis are seen at rates much higher than the general population.
What is persistent mean as opposed to just diagnosis?
So the problem is that this data is, it was survey data, so self-reports. The Census Bureau picked a sample of prisons and jails, and it was self-report from inmates. So it's hard to be specific about what type of hepatitis this was. And I wanted to show some local representative data. This is a study of out of Rikers Island that compared 2 groups. They took everyone that was admitted in the New York City jail system in 2013 and created 2 cohorts, one that was the most frequently jailed by rank cohort, and then randomly selected a control sample of 800. The frequently admitted group had many short admissions compared to the control group, and across the board they had significantly higher rates of serious mental illness, homelessness, substance use, HIV, hepatitis C, and diabetes. So the group that comes into jail a lot does tend to be sicker. This was a landmark study looking at mortality after release from incarceration. This was looking at 30,000 inmates released from the Washington State prison system from 1999 to 2003. This graph looks at death rates, and the black line represents the death rate when they're in prison. The dotted line is the death rate of the general population. So actually, while inmates are in prison, they may have a slightly low mortality rate, thought to be due to avoidance of some of the risk factors such as violence and substance use in the community. However, the period immediately after release from prison is associated with much higher mortality rates, and that risk persists for several weeks after release. And they also looked at...
Does it ever stop being elevated?
I'm not sure. This study only looked till the period. I'm not sure when they stopped looking at the mortality rate, but yeah. So I'm not sure when this sort of tails off. But the thrust of this study was that when inmates are immediately released, they're at much higher risk for mortality, mostly due to overdose, but also liver disease. And the thought behind this is that in a lot of prisons, there's a lot of forced abstinence, which leads to reduced tolerance to opiates, and people come out, especially if they're not on opiate agonist therapy, and end up overdosing.
It does make sense, but you also need to know what the graph looked like farther and earlier to see if that, I mean, I understand the model, but the graph looks pretty flat, and you don't have any idea what it looked like before they went into prison. So I don't think, this doesn't give great support to the idea that what you're saying is the driver. Right? Because I guess it has a big spike in the first 2 weeks, but then it kind of plateaus and it's still pretty high.
Yeah. So I think it's likely that this population does have a higher baseline mortality rate compared to the general population.
Yeah, 50% almost.
But it does, I think it is still showing that the first couple of weeks.
The first couple of weeks look really
outside
perilous.
of release is very perilous.
And it's that first dose that they take.
Wow.
They've lost their ability to metabolize.
Yeah.
You get a little fentanyl mixed in, and then it's like it's all over.
Yeah.
Will a lot of them end up back in prison? What's the reimbursement?
I don't know for this cohort, but it is quite staggering that within 3 years, I think generally 2/3 of incarcerated individuals.
Because they end up back in prison and they're back to the dotted line.
Yeah. I think this was mainly focusing on the immediate post-release period, which is risky, and I think this has important implications for how we manage substance use in this population, and argues for scaling up opiate agonist therapy and harm reduction. So, and this is just more local data. So this study was asking the same question among the New York City jail population in 2011 to 2012. They calculated a all-cause mortality while inmates were incarcerated, which was 1.39 deaths per 1,000, with a total of 27 deaths. And then they looked at the first 6 weeks post-release, and this was nearly around 4 times higher death rates among New York City jail inmates. And again, opiate overdose, drug use, and trauma were significant causes of death. So, kind of drilling in more specifically to liver disease, there is evidence across the country that liver disease and viral hepatitis does cause significant morbidity and mortality in our population, in the correctional population. The Texas state prison system is the largest prison system in the country, and when they looked over 1989 to 2003, 16% of deaths within custody were due to chronic liver disease. Washington State Prison had 70,000 releases during 1999-2009, and post-release, the most frequent infectious disease cause of death was viral hepatitis. And this graph is looking at the Georgia State's prison system and looking at causes of death both within and post-release for their prison inmates. The solid line is liver disease-related death. The dotted line is HIV-related death. So this mirrors trends that we're seeing in the community, but highlights that liver disease, with a significant proportion of that probably being from viral hepatitis, leading to rising rates of death. This was an interesting study from the Massachusetts incarceration system. It includes both all people who have been incarcerated in Massachusetts during their time period. They found that comparing those who did have Hep C versus not, those who had Hep C had longer median hospital stays and higher 30-day readmission. They also looked at the group that did not have significant liver disease, and this association still persisted. So it's not clear that it's directly from Hep C, but that probably this group of population has other medical comorbidities such as infections related to drug use, endocarditis, osteomyelitis that may lead to higher burden of healthcare. And ultimately, one of the reasons we want to treat Hep C is to prevent hepatocellular carcinoma. We have seen that HCC is on the rise in the US, and these trends look like they're accentuated in the incarcerated population. This is again from the Texas Department of Criminal Justice, and they looked over a 3.5-year period and found that their prevalence of HCC during that period was nearly 7-fold compared to the general population, and their death rate was nearly 4-fold. So in summary, the US does incarcerate at a very high rate with greater than 10 million jail admissions per year. There are marked racial disparities. The incarcerated population does carry a heavy burden of medical substance use disorders and liver disease. And it appears that the immediate post-release time period carries a high risk of death from overdose and possibly liver disease as well. So this, I'm sure many of you are aware of, but I'm just going to summarize some of the recent epidemiology comparing the correctional population to the general population. The rates of antibody positivity and RNA positivity appear to be nearly 10 times higher in the incarcerated population versus the general population. General population based on NHANES data, and the incarcerated population. These estimates are not precise because data is much more limited coming out of prisons and jails, and methodologies are not consistent. But it just gives us an idea. And there's data showing that a significant proportion, nearly a third of the population that has Hep C, does interface with the incarcerated population in a given year. This is showing more local data. This is geographic data of newly reported chronic hepatitis C infection rates across different geographies in New York City. This report is put out by the Department of Health every year. And the dark blue spots are the higher rates. And every borough has hot spots of newly diagnosed Hep C. But this little yellow highlighted island, Rikers Island, is far out, is an outlier. And it again goes to show that many of the Hep C infected population pass through our environment, and this is an opportunity and obligation, responsibility for us to serve them. This is some data on our earlier screening period. 2013 to 14, our screening behavior mostly focused on risk factor-based screening and birth cohort screening. We screened about 10,000 inmates that year, and among the different birth cohorts, they were quite high across birth cohorts. And this graph illustrates that there was the line represents the Hep C antibody positive, and we do see a peak in the baby boom cohort, but also a second peak among the younger birth cohort, which we've seen that epidemiology in the community. Screening rates were quite good among the birth cohorts, but among those born after 1965, there's work to be done to improve screening.
Was the screening while they were in jail?
Yes. And since then, I'll talk a little bit about it later, but we've rolled out universal screening on intake. Sorry.
How often do you do the screening? Is it if they come 5 times a year, you'll do it 5 every single time, or is it just a 1 time a year?
It's not always consistent because it's generally offered when people get admitted, but if they have been screened within the past 6 to 12 months, usually the intake nurse will just take the previous results. But we do rescreen people on a periodic basis. So you all have seen this data from NHANES that shows in the non-institutionalized population, the male group and the non-Hispanic group have a higher, non-Hispanic black group have a higher odds ratio of being positive for Hep C. And I just want to contrast that with what we see in the incarcerated population. These are some data looking at differences between women and men. This is a pooled odds ratio of studies over 1985 to 2005, breaking down seroprevalence between women and men. And with any of these studies, there's heterogeneity and differences in screening practice, but the pooled odds ratio suggests that women had a higher odds ratio of being positive for Hep C relative to men. And we also see that in our New York City jail population. There are hypothesized reasons behind this that I showed you earlier, that women are incarcerated more frequently for drug-related charges. So that's the thought behind why among women who are incarcerated, there are higher rates of hepatitis C.
Did they mention if there's any change in the ratio over time? It's pretty long interval that they were looking at, 85 to 2005. Or was it a constant ratio of men to women? Or did it become more women in the more recent studies? Did they comment at all on any change in the trends?
I don't recall if this study looked at that. I'll have to check on that and get back to you. Yeah. This is some data looking at racial breakdown. This is a meta-analysis of 10 studies among U.S. jails and prisons, and found that the pooled estimate of Hep C seroprevalence was higher among white patients relative to Black and Hispanic, but because of the heavy incarceration of racial minorities, the majority of patients with hepatitis in the correctional system are still racial minorities. This is data from our system, which also shows similar trends. I want to mention a word about acute hepatitis C. This is data coming out of Massachusetts, the Massachusetts prison system, where they found relatively high rates of acute hepatitis C in people who come into their system. They developed a screening algorithm where they asked whether there was recent initiation of injection drug use, and also whether they shared any equipment over the past 12 months. They screened 3,400 individuals with this protocol, and I identified 171 high-risk individuals, of which 20% had acute hepatitis C based on CDC case definitions. Based on this, they estimated that there was approximately a 1% rate of acute hepatitis C among newly incarcerated inmates in their system. So I think there's two things I take away from this. One, that there's a lot of high-risk activity that precedes incarceration, equipment sharing, active drug use. And secondly, that understanding epidemiology and continuing to do active surveillance in our in correctional systems is a way to really track community transmission and some have argued as sort of a bellwether of what's going on very recently in the community. So since DAAs have been available, they have been offered in correctional systems. This is a website maintained by Ann Spalding's group that is continuously updated looking at treatment across US state prisons. There is a lot of heterogeneity, and this is mostly 2017 data ranging from less than 1% treated to nearly a quarter. However, if you look at antibody prevalence, it doesn't always match the states that have the highest seroprevalence. The highest three states include New Mexico, Ohio, and Pennsylvania. And that's also where we're seeing the highest rates of overdose death. So there's work to be done in scaling up treatment.
Interesting that Alaska is so high. Is that, what's the main response here? Is it Native Americans or?
I don't know. I'm not sure about.
And there was a
Alaska.
high prevalence of Hep B, right, Andrea?
Oh, yeah,
Well, I understand it, studied that.
yeah.
Yeah, sorry, I don't know Alaska. So in summary, Hep C has nearly a tenfold higher prevalence in correctional populations compared to the general non-institutionalized population. There's variance across state prison systems due to local rates of substance use and incarceration. And it appears that the epidemiology does differ from the community, where women and non-Hispanic white individuals appear to have a higher rate of Hep C in prisons and jails. And I think understanding, having better data on both chronic and acute Hep C in the correctional population is important for us to truly address the epidemic overall. So I'm going to go on to some of our own data. First off, I'm going to tell you about what's happened to our initial treatment cohort. So since 2014, the New York City jail system has been offering direct-acting antiviral therapy with no medical or substance use requirements. We treat as many people as we can. However, treating and scaling up treatment in jail systems comes with some unique challenges due to the transient population and the high turnover. And there's some data to back up that if patients are treated and either transferred or released, they do have worse outcomes in terms of treatment completion and cure. So this is not local data. This is from the Scottish prison system, and it does represent the interferon-based treatment area. But the main purpose of the study was actually to look at outcomes of treatment in prisons compared to the community, which they found there was no difference. But among incarcerated individuals, those who were released mid-treatment did have significantly lower rates of treatment completion and SVR rates. And there's several reasons to this related to transitions of care, and also patients have many competing priorities when they come out of prison. Yes?
Is the SVR rate only in the population that completed treatment? Does that include only patients that completed their treatment, the SVR? Or
It's interferon.
I think it's
Oh, it's 2000.
yeah. I think the yeah, it's out of all the patients.
But you may get to this, but is it reasonable policy to only start treatment if they're going to be in prison long enough to complete it?
So that was really the thrust early on, is to get a sense of who's going to finish. But even that is very challenging because most people have outstanding charges. They're waiting for court, and I'll show you some data that it actually took a very long time, much longer than treatment courses, to get people through treatment. So that's a big challenge that we do have some novel strategies to try to get around that, including using modeling data to input charge information, bail information to predict who might be staying for long enough. But it's still imperfect, and we do have people who get released on treatment, and I'll show you what happened to some of those patients. So the second challenge is linkage to care, like related to people who get released or people who did not receive treatment. The available data shows that linkage to care rates after release are low. This is from the Wisconsin prison system from 2001 to 2015, so straddling the implementation of DA therapy. Out of 3,000 individuals, 18% did engage in care during incarceration, but the majority did not receive Hep C-related care. Among those who were released for at least 6 months, they used surveillance data to track who linked to care, as in who had a viral load or genotype done, and they found that only 9% of those did within the first 6 months. More locally, we have implemented efforts to improve linkage to care. This is a study by Matt Akiyama, who also works in our system. He's faculty at Montefiore, or Einstein. He implemented a one-arm clinical trial intervention that involved providing people pre-treatment with pre-release needs assessment, education, discharge planning, and care coordination. They also receive reminder calls, appointment accompaniment, post-release. But even with this intervention, he found 31% linked to care within 6 months. So I think this is, 31% is not a bad number. There are certainly many individuals that link to care, and 17 started on treatment. But interestingly, those who were on methadone maintenance, felt socially supported, and did not drink alcohol to intoxication were more likely to link. So again, that treating substance use disorder and providing social support is very important for this group. This is the published data on our initial cohort of 104 individuals who received DAA therapy from 2014 to 16. They were only able to get end of treatment viral load on a subset of these individuals, 71%. And they did find that at end of treatment or post treatment, that 96% of them were undetectable. So this was encouraging initial data. We did not have the SVR12 data to confirm cure, but this encouraged us to treat more. So since then, we've continued to scale up treatment, and we built another cohort looking at all the individuals who were treated in our system from 2014 to 17. We looked at SVR outcomes, whether or not they had a lab collected to assess SVR, and of those who achieved SVR, how many had recurrent viremia. This was a retrospective study, and treatments were based on the latest ASLD DSA guidelines at the time. This included people that were treated from the community, and we just continued whatever they were on. And then jail-based treatment was initiated if we had an estimated length of stay that was long enough to complete the course.
Are you allowed to give, if somebody's being released and they haven't finished, can you give them like at least the remaining doses that they can take with them?
We're allowed to give 7 days.
7
And then
days.
we have to work to reactivate insurance, link them to care, get them the rest of their med supplies. So it's a challenge, but we are working on that, and it is feasible. It just takes a lot of care coordination.
And which drugs or pharma companies are you partnered with? What's your arrangement? Are you going to get them?
So there's no preferential drug. We treat with whatever is best for the patient. We have been tending to favor Mavorite or GP as much as possible due to the short duration, but it's just whatever is medically.
For the city?
Yeah, it's a global budget from the city. So that's why there's funding stipulations about how much can be.
Yeah, so I guess Louisiana, they've negotiated with Gilead for just a bundle payment for
Yeah.
all the cases. Do you have a similar arrangement?
No, not right now. And actually, money, the paying for the meds is not really the issue right now. We actually have additional budget room to treat more, and prices have come down over the years. So it's really some of these other issues related to uncertain length of stay, discharge on treatment. Those are really the challenges.
Are these patients, they have insurance, they have medical insurance, or are you just providing them the medication and then when they leave, they get some insurance?
So Medicaid is suspended when people get incarcerated. So it's all paid for by the city while they're in the jail system. And then when they are released, we work to reactivate Medicare whenever possible. Most of these patients are Medicaid eligible, so we'll either do a new application or reactivate suspended Medicaid. And then there have been some that are uninsurable that we can request pharmaceutical assistance for.
Do you have data on the median time on treatment and association with the RNA levels?
Median time.
Like how long these patients have been on treatment? Because they get released?
Yeah. You mean like people who don't finish their treatment while they're with us?
Right.
Okay. Yeah. I'm going to show you like some of the outcomes for people who got released on treatment, and it doesn't break down exactly at which point they were released, but all of these patients, we did everything possible to get them the rest of their meds with varying degrees of success. So the data source for this was we relied on the Department of Health Hep C surveillance registry, which captures all viral load, genotype, and positive antibody results. We continued surveillance through the end of 2018. So this includes both jail-based labs and community labs. And I mentioned the outcomes of interest were achieving SVR, having recurrent viremia, and whether or not they had a lab collected for SVR. And we used log binomial regression to calculate risk factors based on various factors that we thought would be important. This is the characteristics of our initial cohort. So 269 patients were treated during that time period. 181 were jail initiated, 88 were community initiated. And I highlight this length of stay data because this goes to show it took a lot of jail exposure, many days longer than it would take to actually provide the treatment to actually to get people treated. So this is purely the treatment incarceration. And you'll notice the community group, they have much shorter because we just continue whatever they were on, and most of the time they are released before they finish treatment. This is some of the comorbidities. And the point I wanted to make here was that of the jail-initiated patients, a significant proportion of them had history of homelessness, alcohol use disorder, opioid use disorder. And these are traditionally groups that have not accessed healthcare as much. And we in the jail environment are able to provide care for a lot of marginalized populations with the advantage of directly observed therapy. These are overall outcomes of the 269 treated patients. 195 or 73% had an SVR lab collected. Of those, 88% achieved SVR, so this is per protocol. Of those who achieved SVR, 114 or 66% had a subsequent viral load checked afterwards, and 18 of them had recurrent viremia. So these are a breakdown of SVR rates by subgroups. And the main point that we found was that indeed those who completed treatment in jail had nearly threefold risk, a much better chance of achieving SVR relative to those who were released on treatment. And the rest of these subgroups are basically negative data to show you that of all these patient factors, none was associated with SVR. So we should go ahead and try to treat as many people as possible while they're under our care. However, linkage to care and confirming SVR was a challenge. So this is showing our analysis of who had an SVR lab done. The only significant factor that came out was that those who were jail initiated on treatment were significantly less likely to have an SVR lab checked. And this is probably because the community starts already had established care and they knew where to go back to. But those who we started, many of them did not have established care. So that's something we need to work on. I show the rest of these because HIV and those who had HIV and those on opiate agonist therapy, they did trend towards significance for having an SVR lab done, and it's probably a proxy for having some other established healthcare available to check their labs. So I'm just going to, this is showing the same data in a different way. Recurrent viremia, we call it recurrent viremia because we couldn't prove that this is reinfection, but we know that late relapse is quite rare in the DAA era. Based on surveillance, we had 170 person years of follow-up, 18 recurrent viremia events, and that's equated to 10.6 cases of recurrent viremia per 100 person years of follow-up, which is high relative to the data from people who inject drugs. But among some of the most highest risk populations that have been published in the literature, this is a cohort out of Australia with people who inject drugs who have regular injection drug use, and their reinfection rate was around 12 per 100 person years as well. This is a slide to show that patients with mental health and substance use disorders are still less likely to access Hep C treatment, both before and after the DAA treatment era. So, sorry.
Is that because providers presume they're not competent? Because your data would suggest they are.
Yeah, so this is administrative data, so they couldn't prove what were the reasons, but the authors suspected that it could be leftover bias from previous era of interferon-based treatment. Also, there may be restrictions from insurance companies related to substance use. And then also some of these groups.
That's likely in Texas, actually.
Sorry?
That's likely.
Yeah.
That's likely a large part.
Yeah.
Not getting treated.
Yeah.
There's still a bunch of states that require sobriety for 6 months before.
Yeah.
Even from cannabinoids,
Mm-hmm.
which is insane.
Yeah. It's unfortunate. These are.
By the way, that's Monk and Jane. She's one of our former ID fellows here. Who's done a lot.
Yes,
And they're part.
she's done a lot of good work. Yeah.
Yeah.
So these are some take-home sort of summary points. Jail-based treatment with DEA therapy is feasible and effective. However, we have work to do on improving linkage to care, confirming SVR. We are seeing high recurrent viremia rates, likely representing reinfection. We are treating some of those people who do come back to our system for reinfection. But in general, correctional health, the correctional setting is an opportunity to provide Hep C treatment to a lot of underserved populations. So next is scaling back, looking more generally, how are we doing in terms of Hep C care in general for the entire jail population in New York City. This is background to look at what's going on in New York City. Data coming out of the Department of Health surveillance, they estimate 116,000 individuals with chronic Hep C in 2017. Of those known to have, of those who had some sort of Hep C tests since July of 2014, nearly half of them started on treatment. So these are much higher numbers than interferon era, but they do note that we have remaining challenges to link patients to care and training more clinicians to prescribe. So our jail-based cascade of care covered the similar era of 2014 to 17. We looked at rates of screening positive, having a confirmatory RNA test done, being seen by one of our treaters, and receiving DAA therapy. And then these two outcomes we looked at in more detail with multivariable analysis. So this was a retrospective cohort. We included everyone. The analysis was on individual patient level, and everyone who was admitted to the jail system from 2014 to 17. We did exclude some people who never received a medical intake. Some of those people are quickly released pre-medical care. Those who are cured with interferon therapy, and we also excluded the community-based treatment. Outcome definitions. Most of this is fairly straightforward. The screening for Hep C, I'll just note that one thing we did count as positive screening was if someone was aware that they have Hep C, then usually they're not offered another antibody-based test. So they should proceed immediately to get an RNA test done. And then we counted those who received DAA therapy starting from 2014 onward. We looked at a few subgroups because I've noted that length of stay is a significant factor in terms of providing care. We looked at the long stay cohort, those who at least had one jail stay greater than 120 days. And then there's a frequent stay cohort. There's a group that comes into jail a lot, greater than 10 separate jail stays during the time period. How are we doing with that group? And then the HIV positive cohort. And we did look at association with some key patient factors of age, sex, race, HIV status, length of stay. This is serious mental illness, which is a classification by a mental health service. Anyone who has psychotic disorder, depression, and PTSD, bipolar, would be classified as serious mental illness. So this is our cohort characteristics. The total 121,375 individuals were admitted at least once during the 2014 to 17 period. 28,000 in the long stay cohort, 1,000 in the frequent stay cohort, and 4,200 in the HIV cohort. We looked at these key factors of mental illness, ever homelessness, alcohol use disorder, and opioid use disorder. they were all present at a significantly higher rate in the long stay cohort and frequent stay cohort, and also the HIV cohort, which is consistent with our previous study looking at the frequently incarcerated. These are the overall cascades of care for the overall cohort, the long stay cohort, frequent stay, and the HIV positive cohort. There are significant drop-offs in screening rates, linkage to a Hep C treater in jail, and those who started on treatment. The frequent stay cohort did have the highest screening because they had the most chances for coming in admission, getting screened. And the long stay cohorts did have the highest rates of starting treatment. But even then, 14% was quite low. And I'll just highlight a couple of things on this slide. This broke down the cascade for several more cohorts. We did a good job screening the baby boom 1945 to 65 cohort, the HIV positive cohort, and the opioid use disorder cohort. And we saw, as expected, high rates of HCV exposure among opioid use disorder, HIV, and the baby boom cohort. And across the board, our confirmatory RNA testing was fairly high, near 3/4. And we think that's probably because we do pair the rapid testing with immediate RNA testing. And although the HIV cohorts was very likely to see a treater, across the board, our treatment rates were quite low. And this is quite telling in terms of how long it took to proceed through that cascade of care for the various steps. And this is something that we need to work on, taking nearly a year of jail exposure, or over a year, to get treated. This is looking at our two main outcomes of interest: having an RNA test done and being seen by a treater. This is represents completion of the diagnostic cascade and then entering into the treatment cascade. And as expected, the long stay cohort had a significantly higher odds of having both of these done. It's interesting that for the women were more likely for both as well. And we think that probably universal rapid testing was rolled out quite early in the cohort time period for women. And in the male facilities, it was a staged rollout. And likewise, there's only one female jail, so minimizing transfers between jail facilities probably facilitated them linking to a Hep C treater.
What do you think is, so also being HIV infected, right?
Mm-hmm.
What is your explanation? How would, just more likely to be linked into healthcare, or?
The reason why they were very likely to see a treater.
Yeah.
So we do prioritize to try to see HIV positive patients as soon as possible upon admission. And this is interesting because although they saw a person who could treat Hep C, they had low rates of starting treatment. And that's probably because many of these people come in viremic with HIV, and we have historically focused on getting their HIV sort of on track and controlled first, which may not be the best strategy necessarily for all patients. I think we're losing a lot of opportunities to treat co-infected patients because of that. So I know I'm short on time, so the last couple of slides, this is just looking at our treatment starts over the years. We are scaling up, and we would like to continue to do so. We have financial support for that. And overall, the subgroup with higher exposure to jail is sicker with more mental health and substance use disorder. We are doing a pretty good job at screening overall, but given that now we're doing universal screening, I think these rates are probably higher after the period of study. Our use of the rapid test paired with immediate RNA testing is probably what is accounting for higher rates of confirmatory RNA testing. And then we are trying with various strategies to increase treatment. So in summary, the U.S. incarcerated population has a high burden of medical, mental, and substance use disorders. There is a disproportionate burden of hepatitis C, liver disease, and HCC among this population. And I think I've highlighted some of the challenges that we face in jail-based treatment. But with continued and improving support from the community for linkage to care and care coordination, I think we can continue to scale up care for this important population. These are my acknowledgements in terms of treaters and leadership at Correctional Health and our collaborators at the Department of Health who provide a lot of data and data analysis. So, happy to take any questions. Yes?
You guys may already have done this, but do you think that it would be helpful to partner with the NYC HHC hospitals to have like a post-discharge follow-up clinic 7 days so that they can?
Yep. So yes, they're actively scaling up that with initiatives for transitional clinics, both for primary care, and then I also work at Bellevue doing ID clinic. So we try our best to see all these patients, but no-show rates are a problem. So even with that, yeah. Yes.
To what degree do you think that like the patient's readiness for treatment plays a role? Maybe that should be, assessed, like, doing some kind of prep C or something.
Yeah, yeah.
See, like, because maybe part of the reason they're not being linked to care is not our fault. It's just that they actually were never that committed to treatment.
Yep. So that's something definitely we're considering that. I talked to Jeff Weiss about the PrepC tool. I don't think it was validated for like this type of population, and but I think we definitely should look into ways to stratify who's more and less ready for care. In terms of treating people, I think because we have such good support with DOT and ready access to patients, I try to put as little of a barrier to starting treatment while they're with us. But I think linkage to care is definitely a whole other issue, and we work with several community partners for patient navigation, including the Mount Sinai clinics here.
Scott, you had a question? Scott, did you have a question?
Yeah, I was wondering for assessing a degree of fibrosis before they start treatment, is there a standard way that's done, or does it vary by treater? And if it is detected, how is that dealt?
We'd use non-invasive, so at least 2 non-invasive indicators along with physical exam, and if things agree, we go ahead. I think when we're in doubt, we'll just treat as compensated cirrhosis, and we are treating some decompensated patients as well. So the most commonly used are the FIB4 and fiber tests to get a sense of that.
Okay, I think we'll have to end here. Thank you again, Dr. Chan.
Thank you.